Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. Okay, so I'll start things off. This is a case of mine. This is a female patient in her late 50s and a remote history of trauma, 17, 18 years ago, I think, and required an open reduction internal fixation. The way it comes reported is she had a trimolar ankle fracture, required an ORIF, and then ended up with a staph infection, an IND. I think she ended up having a skin grafting, and that was all kind of on the lateral aspect of the ankle. Now she comes in because she's having increasing ankle pain. She's increasingly limited, or maybe decreasingly limited, or decreasing ability to be active. And she's pretty healthy. She is a former smoker. So, that's always something to you want to kind of discuss, like how recently they quit smoking, but it was more than 5 years ago, if I remember correctly. So these are her x-rays. I think Jan got on. Bethany, you're on. What are you thinking when you see something like this? These are the x-rays. Here's the 3-view ankle. And the trouble area, I don't have a good picture, is on the lateral side of her ankle.
It's interesting that, you mentioned the staph infection, and that's kind of really what has me concerned. The x-rays are not very concerning. It shows arthritis, but I'm more worried about if there's some latent infection in this patient and so forth.
So how do you work that up, Jan, Bethany? How do you work that up? Are you guys getting labs? Are you getting, is an MRI any value, or is like tag white blood cell study, or do you just, what's your workup for that?
Yeah, the data's out there that there's not a one reliable test for infection unless it was gross purulence coming out of the ankle. Then it's infected. But for me, I'm getting labs, ESR, CRP, and then this patient doesn't have a lot of hardware, but a lot of times I've staged these or gotten bone biopsies as well if I'm concerned. And I've started using a test called it's like rapid sequencing DNA. It's a PCR testing for infection. That's a send out, just to kind of use as well as another tool to kind of look for any signs of infection here, but very difficult to tell.
Is that the one that gives this? That's not the Synovusure though, right?
No, it's not. It's not Synovusure. Synovusure is just like for the enzyme testing. This one is actually a PCR testing. It's like rapid sequencing. You get results back in 48 hours. But one of the drawbacks that people are saying is that it's, even if something's just like dead bacteria, the test doesn't know, DNA doesn't know the difference between dead and alive. So, but.
And then are you biopsying? Is that like a biopsy of the bone, or is that the synovium, or what is that?
I would biopsy the bone, but I mean, it's, you don't know where to biopsy. There's no like lesion here where you're like, oh, that. So, I mean, it's a random, and I tell that to patients, it's very random. Like, I'm going to pick a few points here and there, and, I may get it, I may not. But some of these are, high risk things, especially if I was thinking about a total ankle. But everything you've told me right now is probably a fusion. But if I was thinking total ankle, I'd be very aggressive trying to make sure that there's no infection.
Yeah, I usually get labs, and if those are elevated, then I'll do the biopsy staged. If they're pretty benign and it's been a long time, it's not like 6 months, 8 months, 1 year kind of time, but it's been more like 10 years, then I'll usually I'll get the labs and then do the fusion if the labs aren't elevated, and take cultures at the time of the fusion.
One of the things about her is her skin, especially laterally, it looked bad. So I wasn't that excited, but at this point I was still entertaining the possibility of a total. But when I looked at like that anterior skin, it was a little suspect. I wasn't sure if it was going to heal or not. So I ended up, and I think I checked her labs. They were unremarkable, but I kind of wanted to test it, so to speak, to see what her skin would do. And so I ended up doing hardware removal, except those 2 screws. I'm not really sure. I don't know if I have a good rationale. I think it's because I didn't want to go through the lateral skin, actually, is why I didn't go after those. And took out the posterior and did a little bit of an anterior chylectomy, took a biopsy from the joint just to get rid of the hardware there, thinking that if everything healed up okay, maybe I'd offer her a total. So did a little exostectomy out the front, but sure enough, that anterior medial wound with like no hardware underneath it did just terrible. Just took forever to heal. It got a big scab. It just was not, I think it took a month or two to fully heal. So for my mind, that was like enough of a test that I thought, okay, I don't want to go through that again. And so now what? You know, the skin's not going to heal well. You know, she's got arthritis. I think I have a little CT scan. This is where we're at now. So she, you know, it's pretty straightforward in terms of tibiotalar arthritis and the diagnosis. But how are you going to approach this case for, let's say, for fusion? Because I think ankle arthroplasty is off the table from my perspective.
From the back, maybe, right?
Yeah.
That'd be nice, but she'll be short after that because you'll have to cut you can't like bone graft her in the front. I don't know. I probably shorten her a little bit, so do it from the back, shorten her, and shorten the fibula.
Jan, I'm gonna go back to the X-rays. Lateral. Maybe he had to jump off. Yeah, that was my thought too. Is to go from the back. I didn't really want to go from the front. I didn't think a lateral approach was very good because I was concerned about the skin. Maybe if I took the fibula out, maybe it would have been okay. I don't know. But all those thoughts. What about how do you get that talus?
The one
back?
thing,
I mean,
sorry, Nick, I would probably just try to do this percutaneously.
okay, tell me more.
Yeah, so I'd probably make 2 incisions and take a high speed, take a burr, not even necessarily high speed burr, but one of those, you know, just forget what you call it, that one of those burrs that irrigates. I can't think of the name right now, but and just put percutaneous screws in this. You know, instead of putting any plate or anything, I think you could. I mean,
How do you?
there's not a lot of cartilage
you would
here. I think
accept-
you just need to really freshen up the joint edges here.
Okay.
So you would accept the deformity. You'd say, well, it's
Oh
worth
yeah, I would.
MIS to keep her to
I-
accept the deformity.
Yeah, I've gone past the deformity already. They had.
Yeah. Okay.
So you would leave it a little bit anteriorly translated.
Yes.
A little plantar
I
flex.
think to get it posteriorly, you would have to do this open then. There's no way you could do that. I mean, I don't think you can do that percutaneously or minute MIS. I mean, maybe there's someone who's very facile in it, but I think it'd be extremely difficult. So I just kind of fuse it where it lies.
So I went from the back. So this is my little summary. I went from the back, and I did use a high-speed burr, I guess. But went from the back, exposed it. I cut the fibula kind of between the 2 screws. The 2 screws were kind of I ended up leaving them because they kind of were a landmark for seeing me close that down because she was still in some varus. So I wanted to close that down. I think I took down some of her medial mal as well, but I was really trying to get that translated posteriorly. But like Bethany said, this ends up shortening it quite a bit by taking out that big posterior piece. And this was I felt like this was one of those cases where you kind of get into it, and at some point you wonder, am I going to actually be able to do this? Is this actually going to work? Like that, was thinking about this morning, and that's really how I felt at this point. But after, you know, some sweat and tears and a few words, it started to kind of move on me a little bit because it was really stiff, as you might imagine. But I did shorten it. 100% agree, and was able to get some provisional guide pins in, and then I used a posterior plate on this in this case to fix it. Close down her lateral side, and you know, nothing too fancy, screws going in across that area. I didn't use any percutaneous screws. I felt like I got good purchase and compression. I used, I think, some proximal tibial bone graft, autograft into that area, and these are my immediate post-ops. You can see where I cut the medial mal, and in an effort to get that translated posteriorly. And then these are kind of the initial post-ops, and these are, I think, at 6 months here. And so I was able to get it translated posteriorly. I think it was a nice, you know, she healed fine. This incision healed fine. You can see I translated that talus back. I did shorten it a bit. and you'll be darned if you don't notice. Hopefully the volume's down. Is when I think the thing that's amazing to me on some of these ankle fusions is how well they can move after surgery. And I think but part of it's getting that alignment right, for sure.
Hey,
So,
Nick, can you go back to your intra-op film?
yeah, of course.
Okay, keep going back. Keep going. Keep going. Yeah. So, like, can you say, like, kind of the instruments that you used here, what you kind of
Yeah.
had available and everything? Because I
Yep.
think
Yeah, that's good.
these are key things. It's not just plates and screws in the end.
Yeah. So at this point here, I think I had some the couple distractors in there. I think you see the wires. I was using the K-wire distractor, the Weinraub, or the Hinterman, depending on what you call it. At this point, at this picture, I have a lamina spreader like in the joint. I use the burr to get all the way down because that's not I mean, you can't see much when you're coming from the posterior side. So I did use that percutaneous burr, the MIS burr, to get in there and help prep the joint and get that prepped from the front. I mean, outside that, then it's a lot of osteotomes, curettes, rongeurs to clean it out. I think having things like small saws can be helpful as well. I do use a pituitary and curettes and that kind of stuff. I'd be curious if Jan, Bethany, I know the answer for you, but Jan, do you have the what do they call it? The power osteotome? Do you have anything like that? About CYNs.
So while he's thinking about that,
Yeah, I don't have it. I sorry, I'm intrigued by it though. What is it?
It's basically an instrument that you put it on. It's kind of like the power rasp, I guess, but it has an osteotome that goes on, and it kind of can prep the joint, and it allows you to decorticate and remove all the bone. It works pretty well. It's obviously dependent on how sharp the osteotomes are.
Who makes it?
I'd have to look it up. I'm not sure.
Oh, okay. All right.
Yeah,
I
I
was
don't
just
have
curious.
it, so yeah.
it's one of those things that you ask for and then they bring it in and then they don't have the handset for it.
Yeah, or they're dull, and
Yeah,
it doesn't work.
or they don't. Yeah. So
A couple of
one of
questions
the
here, real quick. So it's the low speed, high torque MIS burr. Yes, that's correct. Smoker better for TAR fusion. Interested in this panel survey on that. If you have a smoker, my opinion is bad for both. Some of my worst arthroplasties have been smokers. Same for fusions. You guys, are you 100% no for fusions or total with smokers?
I won't fuse an elective patient or do arthroplasty if they smoke.
Okay, Bethany.
I will do a fusion with heavy counseling, but I won't do an ankle replacement.
Yeah. Mike asked, what about ZYNs? No one's talked about that. What do you mean? Maybe I'm not clear what that ZYNs, ZYNS, apostrophe S. Zosin? No. Maybe I'll have him, Mike, I'll maybe have you clarify in the chat.
It's just like nicotine pouches.
Oh, what do you think guys think about that, or vaping? That's another popular one we get. Do you let them vape?
No, I
No.
test them.
You
I mean,
test
if they
them?
lie to me, I never know, but I test them. If they ever tell
Yeah.
me they're a smoker or vapor, I'll test them
Yeah.
before surgery.
Okay.
But what do you think about the test? Because the test takes like 2.5 weeks to come
Oh,
back.
I know. They could start up again. I agree with you. I learned that like one of the first time, I think they sent it out to like Utah or something from our institution, and it takes like 10 to 14 days to get back.
I mean, so the patient knows what date you're going to do it.
Yeah, I mean they could lie to me. I mean I'm sure they lie.
They do. Don't worry.
But they had to be honest at least for the test. So
That's true.
What do you think about I wanted to ask about the incisions on this. So if they have a healed lateral incision, lateral fibular incision, or that was healed, doesn't look great, and you want to do this approach, I mean, I've gone trans Achilles, like direct center. What do you do if you have to make a posterior lateral, like?
I've gone trans Achilles as well. Jan.
Yes, I think it's a great approach. You see so much if you cut out the Achilles. Go through it. I mean, it's beautiful.
They need they need a lengthening anyway. I'm pretty sure I went posterolateral on this. It probably was, right, posterior lateral to the Achilles mostly, if I remember right. But you can go posterior medial too, but I think that's harder to get over the lateral side, and certainly hard to cut the fibula in that setting as well. So I think the trans Achilles is a great option, because a lot of times that skin has not been violated.
Another question for you guys, just polling us, because I think this could be helpful from a rep standpoint. What about the dressing? Anybody using any like wound vac, specialized, silver dressing, any other tidbits? I've seen those things on LinkedIn where the suture guard or something.
Suture guard, hemi suture guard, yeah.
Anything like that? I mean, just like, curious what everybody's thought is on that.
I'll use jump start sometimes because it's kind of voodoo-ish, but
that's from Arthrex, isn't it?
Yeah.
Like,
yeah.
Seems to
With
work.
the battery.
Yeah.
With the battery in it.
Yeah.
Yeah, I'll use that sometimes. I don't usually use a ton of incisional vacs. I will occasionally, if the incision, you close it and you're like, oh shit, I might put an incisional vac on it. I've been bringing my patients back really early, and I used to not do that, but man, I'll bring them back at like 3 or 4 days just to get that gross dressing off, and then put a new clean dry dressing on, and that seems to be helpful.
Sometimes, Bethany, you've taught me that sometimes using like an Uniboot early on just to help with the swelling can really go a long ways towards promoting some incisional healing as well.
Yeah.
So what do you guys use in Uniboot? One of my buddies who does a lot of total ankles does like an Uniboot, specialized like pressurized dressing. Like, how do you guys get that and so forth? I mean, is it well tolerated by the patient?
Mostly it seems to be well tolerated by the patient. Some of them complain about the swelling, or the pain from the swelling, but that has been minimal. I can't tell you much more of that, because I just say put an Uniboot on, and the cast techs have the cream and the dressing and the A strap, and then I usually put a temporary splint on behind that.
Okay. So that's good. That's some good tidbits. Good questions from everybody. If there's more questions, make sure you drop them in the chat. Anything else to add on this case? I'm intrigued by this percutaneous approach, Jan. I thought about going arthroscopic on it as another option, but I'm not sure I could have gotten in there to do much.
I don't think you need to go arthroscopic though, because I don't think you need to see anything.
Just run the burr.
Run the burr, because you would do this over X-ray. Because if you look at your CT scan that you had initially, you really didn't have any, I would say probably very minimal to any cartilage anywhere.
Yeah.
So I think that's why that's how I would do it. I would just do it via via fluoroscopically. And I've done it on a couple high risk patients before, and I've been happy. It's not my go-to. It is on high risk, but if someone's otherwise healthy, I wouldn't just. I mean, I want them to get a good fusion. I want to see the joint. I want to get the cartilage off, and so forth.
The one question that came up here was, anterior versus posterior, if you're thinking about a total ankle sometime down the road. I mean, I can't imagine this patient ever would be a great candidate for a total ankle, but it's an interesting question. I don't think it burns you if you do a posterior approach fusion, and you want to come back and do a total ankle, but you probably have to stage it if you wanted to do that, unless you're putting them in backwards, the total ankles.
They make reverse total shoulders. Maybe we can do a reverse total ankle.
Sounds like an idea. Sounds like a good
No,
idea.
dude, somebody went to some place to have that done. That's what he told him he was going to do. Put it in from the back.
I think there's a good chapter.
Have you seen those total ankles? Speaking of which, I think most of us do a direct anterior, or I don't want to say direct anterior for a hip, but like an anterior approach for a total ankle. Is that correct?
Yes, but some cases I'll use that modified anterior medial approach. Like that's what I would have used in this case, because she had that medial incision, and those heal pretty well.
Experience with the the Zimmer total ankle where you go from the side?
A little bit. It's been a minute, but yes, I've done, I don't know, 15 maybe,
Okay.
number of years
I
ago.
always wonder about some patients, whether if they're high risk incisions, but then I worry about, like, I've seen a couple, and I've only seen the ones that gone bad, so I can't, I'm biased, but they've developed like fibular non-unions and have had issues.
Yeah. I mean, that's the
And-
downside, but the advantage is, now you have, if you need to do some, lengthening of the fibula for some reason, or the skin across the anterior ankle is not as good. Conceptually, it's hard for me to picture it because it's looking at it from the side, but I'm so used to looking at it from the front. So I think conceptually it takes a little bit to kind of get used to it, and balancing and all that kind of stuff. But yeah, I mean, there's people that can do it really well. And it's a good option for that. It's kind of nice to have that option if you think the skin in the front's not that great. All right. So as you might guess, most of these are going to be post-traumatics. What do you tell patients in terms of your non-unions for ankle fusion? Is it 10%? Is that what you kind of usually throw at them? That's what I tend to use. One out of 10.
Yes.
Okay. Bethany, is that what you use as well?
Yeah, I guess I probably don't say it's quite that high, but then on the other people that I do it on, for like the diabetics, I tell them it's like 60%.
Yeah.
It's really, really high.
Yeah, I just, I was kind of going through some things and thinking, how do you counsel them and stuff like that. But I think 10% seems reasonable. Subtalars maybe a little bit higher, interestingly.
I think a lot of the ankles that like you and I are doing though, are probably in that range of 10%, also because they need some sort of bone graft or some sort of structural correction.
Yep, deformity correction for sure. What foot position? What do you look at for ideal, just in terms of the reps, kind of understanding like what we're looking at in the OR? Let's take like the sagittal, like from the lateral. I kind of showed how we tried to pull that talus posteriorly. I mean, try to gear to get that a couple millimeters behind the axis of the tibia. I'm assuming that you all do the same. Unless you're doing it MIS, maybe it doesn't matter then.
No, I mean, I still try to get it back there. I mean, I'm just, I think what you mentioned, I think yours was an excellent alignment. I think that's a great way to do it.
And then coronal, we talk about varus valgus. So you want to ideally a few degrees of valgus alignment, like 10, I don't know, I tell people 10 degrees of valgus, which tends to unlock the hindfoot joints, so allows some more motion. And I think that's why they get that, that lady that I showed the picture, the video, you can see her foot moving back and forth pretty well. We do tend to tell them 5 to 10 degrees of external rotation. So what you'll maybe see is us line up like the second metatarsal in line with the tibial tubercle. What do you guys do? Bethany, Jan, is that how you look at that?
Yeah.
Yeah. And then translation in terms of, getting that centered. Or the dorsiflexion. That's what I meant. That's what I meant on the sagittal. How much dorsiflexion? I always think I'm good, and it always looks a little more plantar flexed. I've heard people say go for 5 degrees of dorsiflexion. You'll probably be about right, which I think is actually pretty good advice.
Yeah,
Okay.
but one thing, Nick, are
Yeah.
you saying 5 degrees of dorsiflexion, like if you're looking at your lateral of your x-ray, or you mean clinically?
Yeah, that's a good question. I think clinically, that's what I'm really looking at it clinically in the most critical fashion. Sometimes I get a little fooled looking at the lateral x-ray and I think it's pretty good, and then I end up being a little bit more plantar flex than I think. How about you guys?
Yeah, I'm doing it more. I mean, I look at the x-ray, but there's a lot of motion, like you said, a lot of times do the talonavicular. So as long as the x-ray kind of matches my clinical exam, I'm okay with it.
Yeah.
But like you said, I would err on being a little bit more dorsiflex than plantar flex.
Yeah, for sure. Yep. And varus, a little more valgus than varus, for sure. It seems like that they don't like the varus very much at all.